Hello, Dr. Darren Naugles. Welcome back again for part 2 segment of the discussion on COVID. 2+ years since COVID. Now what? That is the million-dollar question. You started in segment 1 and we went all through testing and vaccines, and you shared a few nuggets that I'd never heard before, which I know the audience who's listening to that segment will appreciate. So now I want to let everyone know that I'm Charmaine Reeves. I'm the founder and CEO of AngelsAreNetworking organization, which is an organization for entrepreneurs who are serious about growing their small businesses. So we get them involved, to get them leads and referrals, get them networking, get them access to other people. And we are a national organization and also international. We have members in Canada, Colombia, and across the globe. So Dr. Darren is a board certified emergency medicine physician and a fellow in anti-aging medicine and functional and integrative medicine specialist in metabolic and functional medicine, which is one of my favorite things about medicine now in the 21st century. His advanced approach targets the root cause of issues and early risk factors to promote the highest expression of health in all of his patients. I know Dr. Darren personally. I'm honored to call him a friend, and he's an esteemed physician in his field. And when I tell you that he really cares and he takes the time when someone comes into the ER to really try to get to the root cause of what is going on and make sure that they leave feeling that they were seen and heard and also feeling better. He's also the co-founder and program director of Elite Medical Associates, which is a center in Norcross, Georgia, that caters to natural and holistic approach to medicine. All right, so you can look that up and maybe reach out to them if you're in the Georgia and local to the Norcross area. And we are going to pick up and jump right back in to talk about therapeutics.
COVID, ranges from its symptoms range from people who are asymptomatic, meaning no symptoms, to really respiratory failure. I think that, when you ask, when should we be worried and when should we go to the hospital?
Yes.
And first of all, that depends on the person. It depends on your medical problems. It depends on how old you are. I mean, people who have COVID, who have a cough, who have a fever, do they necessarily need to go to the emergency department? I don't think so. But the older you are, the more medical problems you have, the more immunocompromised, then I think that when you have a fever, you should take it serious and either seek medical attention, whether it's going to the emergency department or whether it is following up with your primary care doctor and being seen so that they can kind of guide you on how to treat it at home, or whether if you need to go to the hospital. The symptoms range from just fever, body aches, cough, loss of appetite, fatigue. But when you start getting into where people are becoming confused, because that's kind of one of the symptoms that we worry about when people who are into their advanced stages of the infection. If you're having trouble breathing, if you're passing out, feeling extremely weak where you feel like you're going to pass out, these are things that a young person should, want to seek medical attention. Should patients come off in the beginning of their interview or in the beginning of their assessment and start, asking doctors about treatment plans? You have every right to do that. I never, get mad at any type of questions that a patient asks me. Some of them are good, some of them are bad, but you got to take it like a grain of salt. A good physician will explain to the patient so the patient wouldn't have to ask. When a patient comes to the emergency department, do we test everybody for COVID? No. If you don't have symptoms that are suggestive of COVID, we don't test you for COVID. So we won't have that conversation with you unless, we think that you have symptoms related to COVID, and if you test positive for it. Okay. Then that opens up the dialogue to say, okay, what's the next treatment? Is there a home treatment? Do you need to be admitted to the hospital? And a good physician will go through that in detail with you so that you're not left the hospital not feeling reassured. That's the worst thing, that a patient can leave the hospital feeling unassured. We have to reassure you that, whatever question that you have, we have to reassure you And if we don't, then we need to sit back more and talk to you and explain. I'm talking about the patients who are discharged, because when you're admitted, it's a whole new different level of care, and we won't get into that, because most of the people who are going to test positive for COVID are going to go home, because that's where the trends are going. So there are treatments. If you test positive, you can receive what we call monoclonal antibodies, which are basically antibodies that were given by a plasma donor, and you can receive this treatment. You can receive it at our hospital, and I think there's certain infusion centers, outpatient infusion centers, where you can receive the antibodies. And these antibodies are for people who've had the symptoms for less than 7 days. So if you come in and you say, I've been having these symptoms for 10 days, then you don't qualify for the monoclonal antibody infusion. So if your symptoms have been going on for less than 7 days, then you qualify. Or certain things also qualify you for the antibody infusions, are basically if you're high risk, if your BMI is greater than 30. I've never declined anybody for the antibody infusion therapy, because most people meet the criteria. So the monoclonal antibody infusion therapy has been FDA approved. There's another medication called Paxlovid. That is a medication that almost everybody can get. But another thing that Paxlovid is not recommended is if you had symptoms greater than 5 days and you're not hospitalized. Monoclonal antibodies have been FDA approved. Paxlovid have also been FDA approved. And then there's another one along that family of Paxlovid is called molnupiravir. And basically, and let me just clarify this to people, most people are going to qualify to get this treatment. One, high risk, you have to test positive, and also you're not hospitalized, and you have to have symptoms within 5 days. One of the other things that I want to talk to you about is about the vaccine. There's another medication out there that's been FDA approved, to where if you had a bad, serious reaction to the vaccine, most people, most people want another option. So patients who had bad reactions to vaccine and they can't get another vaccine, there's another medication called Evusheld, and it's spelled Evusheld. It's a combo drug, and it's shown to reduce the risk of COVID infection by 77%. There's 2 injections you get. There's ejection in the beginning, and then there's ejection in 6 months from that. So what is Evusheld? Evusheld is basically a protein that we give you that attacks or binds to the spike protein on the COVID. So it reduces your risk. So it's almost acting like an antibody therapy in a way, but it's not. But it is a drug for those who are at risk and who basically has had serious reactions to COVID vaccination. So all you patients, or all the individuals, if you don't want to get the vaccine because you've had a bad reaction to it, then ask your primary care doctor about Evusheld. It's spelled Evusheld. Not for patients who are currently infected. There is scientific data that most of the transmission is through air droplets. It's not direct contact. So I guess but I still believe in good hygiene, wiping down stuff, washing your hands. So we know that it's done by droplets. Now, this is what I do when I go into work, and I share a same workstation with other doctors. So, and I started doing this now. When I walk into work and somebody shared that workspace with me, I would grab the computer, I would grab the mouse, and I would wipe everything down. That's just what I do. But am I wiping down everything? No. Am I wiping down my cell phone? No. But if I think that somebody's going to come in contact with something or that I've had, then I'm going to wipe it down. So aerosol meaning droplets. Like if I sneeze, then I'm expelling or I'm putting somebody at risk. Just because you're exposed to COVID doesn't mean that you're going to catch COVID. The transmission rate is probably I can't remember the numbers, but I'm probably doing a ballpark, it's about a 50 to 60%. So if I live with you and you have COVID, then I'm not guaranteed, it's not 100% chance that I'm going to get the virus. It's probably a 50-60% chance. So there's a 40% chance. This is why people say that, oh, my parents had it or my loved ones had it, and how come I didn't get it? That's because its transmission rate is between 50 and 60%. So you're not going to catch it. You're not going to catch it 100% of the time. So you may be that lucky 40% that may not have got enough viral load. And plus, it's also dependent on viral load. It's how much you've been around the person, if they're coughing on you, if they're sneezing on you, because if they're doing these things, they are producing a lot of viral load into the air for you to breathe, because the transmission rate depends on viral load. You remember that saying where they were like, the people who are asymptomatic are the super spreaders?
Yes.
I have to look back at that and maybe not agree, because the infection rate is determined by a viral load. So if you're not symptomatic, then you're not producing a lot of viral load to expose to people. I leave that all up to the airline. I'm not a politician, so I'm not trying to make laws and mandate regulations. I just use common sense. I would, only because one thing is because I'm going to be in an area, a confined space for a longer period of time. And I'm not worried about me having the infection, but when I go home and I go back to work, then I have to be concerned about the people I take care of. That's a big topic to debate, because really, I think that nobody's right. I mean, you have the right people who says don't wear a mask, and you have the left people saying wear a mask all the time. And like I said, I'm always in the middle. I see both sides of each. I wear a mask at work, and when I go home, I cannot wait to take that thing off. And when I'm driving home, if I'm going into the grocery store, I'm taking off my mask because I wore it for 8 hours. Hospital officials should wear masks. If you work in the hospital, you work in a nursing home, you work in a nursing home, you should wear a mask, because you are around people. Again, you are protecting people, not yourself. In hospitals, it may be in other places, but in hospitals, I don't think that that's ever going to go away. I think that employee, if you work at a hospital, 10 years down the line, we're going to still be required to wear masks. As we know, COVID-19 is the parent virus. That's where these variants originate from. Basically, a variant is formed when you have constant mutation of a virus. In the 3 variants that I know of, the one that we first became knowledgeable of is the Delta variant. The Delta variant was 50% less transmissible, but it caused severe illnesses. That's why the variant was such a big deal. So when we think of a virus, we look at its virulent state and its infectious state. Infectious state is basically what percent is it transmissible. The virulent state is how sick people get. So the Delta had a strong virulent, meaning that people got sick really bad, but it was less transmissible. The Omicron, basically, it was less virulent, but the transmissible rate was much higher. So the next one that I've heard of was the Deltacron. And we don't know too much about that. All I know is it's in Europe, it's in France, Denmark, Belgium. We don't know the infectious rate, we don't know the virulent, but we do know that it's there. As long as the virus continues to spread throughout the population, it will continue to mutate. The life of the virus depends on basically the dependent host, okay? Meaning that if you're immune to it and you have immunity to it, the virus is basically destroyed immediately. So we don't give the virus enough time to mutate. It takes time for the virus to mutate. So people who, and this is just my theory, and I read it in literature, to where people who don't have immunity, the virus is slowly reproducing and slowly living within that host. Remember, the longevity of that virus is dependent on the host. If the host dies in a day, then the virus dies with it. That's why the Ebola virus, that's why a lot of people didn't die from Ebola virus. It's more deadly. A lot of people didn't die from it because the host died in 1 to 2 days. So the virus died with it. So if the host isn't around, the virus can't survive, the virus can't mutate. That's why they're coming up with all these guidelines on when to get boosted, who should get boosted, and whether if these boost shots are going to have to be part of our healthcare regimen treatment line, just like we do flu shots every year. We may have to start doing COVID shots every year. I think that for now, in the near future, you're going to need a vaccinator card to get into these countries.
I've learned so much. You broke that all the way down for us, and I really appreciate it. And I want to thank you so very much again. I know that you're very busy, and I appreciate you taking time out to come and just level set, give us a reset on COVID 2+ years later. And I hope that next year that we can maybe do it again, right? Because who knows, right? Three plus years later, what is going to happen?
Right.
I really appreciate it so much. And I know that everyone who's going to be listening to this, that it's going to be educational, informative, beneficial, and actually a blessing to others. And you are a blessing to me and in my life. And I really appreciate you for doing this for the community. So thank you so very much. And I will see you before next year, but I will see you again to do this again next year, okay? Thank you very much, Dr. Darren Naugles.
Thank you too, Charmaine. Thank you for having me. I enjoy being part of the Angels Are Network. And I also, the most important thing, I enjoy being a friend and a neighbor to you. So I am here whenever you need me to speak. I just want to, share my service to the world and share my knowledge to people who need it.
Well, I will say it's a little bit more than that, Darren. You're sharing your heart because you are doing this and it's because you care. Well, you're a doctor, right? Do no wrong. So you have a heart, but it doesn't matter. There will be, there may be other doctors who wouldn't take the time out from their family and everything to do it. So I know your heart, and your heart came through with this. Thanks for being transparent and talking about when you maybe sometimes cry after talking to some of the patients. So I really appreciate that. And if this gives others an opportunity to know the other side of Darren, thank you very much, Darren. Be blessed.
Thank you.
Thank you again.
Thank you. Bye.